Start. Um, Thank you, everyone, for your time. I want to talk about a One Health concept of antibiotic resistance. I know during these sessions you've been hearing about LTACs and use of antibiotics appropriately in the hospitals and how to try to curtail some of the inappropriate use. But antibiotic resistance is actually much more than just taking care of the hospital setting. We at times working in the hospital feel like, we're the epicenter of causing all of this stuff, but I'll go through some really well-defined scientific concepts that are accepted. And One Health is really the way future for all of this. What is One Health? It's defined by the WHO as a concept and approach of designing and implementing programs, policies, legislations, and research in which multiple sectors communicate and work together, a novel concept, working together to achieve a better public health outcome. And the areas of work where One Health really does mean everything is antibiotic stewardship and use of antibiotics. It's really, you need multiple sectors to collaborate, not just this chief medical officer and the infectious disease doctor and the CEO of the hospitals, but much bigger picture of this. And I became acutely aware of this in 2008 when I was in Delhi talking to the city hospitals of Delhi when the first NDMs were coming out. And we'll talk about that a little bit. So this is an old Consumer Reports, and it talks about how to stop a superbug, and you can see it's in the general public now, and it's really all over the press. And in 2015, under Barack Obama, well, it feels like a century ago, National Action Plan for Combating Antibiotic Resistance, and this was the White House summit that was called because they recognized the problem with antibiotic-resistant bacteria and the fact that we did not have antimicrobials that would actually work. And the IDSA and CDC and everyone else got into it and have an implementation of 10 new antibiotics in a decade, some of which is working. This is the new National Action Plan for Combating Antibiotic Resistance, and this was in 2020 to 2025. And the goals of this from the U.S. government, it's called the National Strategy for Combating Antibiotic-Resistant Bacteria, or CARB, lays out 5 broad goals. One is to slow the emergence of resistant bacteria and prevent the spread of resistant infections. Easy, right? I think most of the infection control practitioners have this down like in a jiffy. The second thing, I'm just being very facetious here. The second thing is strengthen the national One Health surveillance efforts to combat resistance. So now the federal government has gotten the message that One Health is the way to try to prevent antibiotic resistance, because the third goal is advanced development and use of rapid and innovative diagnostic tests for identification and characterization of resistant bacteria. And this is where the proteomics, and it's not just it's not just the ability to do whole gene sequencing, but the ability to immediately identify within hours of a patient coming into the hospital whether they have a bacterial infection or a viral infection. That's a pretty big deal. The second thing is, if they have a bacterial infection, is it a bacteria with resistance patterns that require broad spectrum antimicrobial coverage, or is it a simpler bacteria that we can use narrow spectrum coverage? And these are all pretty much almost ready to go. They're in phase 3 trials. There's a lot of exciting, rapid, innovative tests, and it's not just doing a procalcitonin. And then the goal 4 is to accelerate basic and applied research for the development of new antibiotics and other therapeutics and vaccine. When they talk about other therapeutics and vaccine, you're talking about reconstituting the microbiome, as well as other therapies. And you're seeing that in some of the C. diff approaches. And then vaccines, of course, we're up to our eyeballs in vaccines, of course, now that we're in COVID, but that is a whole different ball of wax. And goal 5, improve international collaboration and capacity for antibiotic resistance prevention, surveillance, and control in antibiotic research and development. So really big, broad goals for the national strategy for combating antibiotic resistance. And so where does all this mean? So I think I've given this talk like 4 or 5 years ago when we were talking about One Health concept, like 2018, 2019, for the group when we used to actually meet together and see people. Now that we're all, a Zoom sort of conference, it's a little different. So it's basically a collaborative, multi-sectoral, transdisciplinary approach, local, regional, national, global levels. And it involves humans, animal, plant, and environmental health are all connected. And the difficulty with this is, remember Oprah Winfrey when she used to be on TV and she was talking about the the exporters, the people who are the beef producers and the feedlots and how bad it was for you. Well, guess what? Oprah had to bow down to that because that was such a powerful lobby because they were afraid that beef consumption was going to go down, and they really mounted a massive campaign. So imagine this times 100, because you've got large sectors of the industry that have entrenched reasons not to change things. And it has to do with animal husbandry. It has to do with farmers. It has to do with large chemical manufacturers. It has to do with waste management. It has to do with hospitals. So lots and lots and lots of different interests out there that actually have to see one goal. And this is basically antibiotic resistance spread, and it spreads very fast. I think the COVID pandemic has shown that, except antibiotics are much slower than antibiotic resistance, and bacteria is slower than the viruses. But the amount of people traveling is tremendous. This includes 330 million travelers arriving in the United States at more than 300 points of entry. So lots of people coming in lots of different ports. And so you could basically have a resistant bacteria that goes from India to the United States in basically 18 hours. And so this was the headlines way back, Good Morning America and The Guardian and other newspapers where I learn all my medicine from. As we call it, the New York Times Journal of Medicine now with COVID. So this was something that we had to deal with a while back in 2015. Remember when we were doing ERCPs and they were spreading basically CREs with ERCPs because of the ports. That was a big deal that made national news. And then the Guardian had a huge deal about overuse of antibiotics and causing lethal infections because we were running out of antimicrobials to treat bacteria. As a classical consult that we get now more and more. This is a nurse working in the VA, was seen in Loyola where she had a UTI, treated with ciprofloxacin, underwent cystoscopy late February, this is a couple of years ago, recurrent symptoms, and then saw her primary care in May, and then started on Cipro again with a pan-sensitive E. coli. She had multiple courses of antibiotics with Cipro, trimethoprim sulfa, and then a urinary antiseptic, which was nitrofurantoin. And then, lo and behold, she grows CRE only sensitive to gentamicin. So there's a whole host of questions. How did this happen? How do we treat her? What do you tell the people at risk at home? How do you transmit this stuff? And what do you say to her patients? Because this is a person who's obviously has now been colonized for a period of time. And what do you say to her employer? I think the answers are fairly simple for that stuff like that, because if you're previously fairly healthy and you have good hand hygiene, you generally don't transmit these bacteria. And so those are all easy answers. The question is, how did he get there? And a lot of it has to do with pressure, and it has to do with consumption of food and other areas. It's not just the antibiotics we're giving. Common causes, common clinical issues we deal with, is pneumonia. Do they really have a pneumonia? As Bob Weinstein used to say to me all the time, is it a pneumonia? They really don't have a pneumonia. They just have heart failure or a little bit of abnormality in their chest X-ray. So these are common clinical issues you have to look at, and I know the previous sessions have talked about this. Urinary tract infections or not, I'm a firm believer that you basically should not almost ever send a urinary culture because they're just a reason to give more antibiotics without a really, clinical indications. And then wounds. Culturing of wounds, to me, should be a mortal sin for most folks, because all you do is you end up culturing the thing that grows there, and then you end up treating and then driving more and more resistance. And the interesting part about all this is recently I had a patient where I decided not to treat the wound because it didn't look horribly infected. And I get a call from a pharmacist, who's doing his job. Of course, a lot of these pharmacists now are not present at site, so you can round with them. In a lot of these centers, as a cost-cutting move, they're somewhere else. In fact, this pharmacist was out in North Carolina. And he says to me, well, you're not treating us, it's resistant. I said, well, I don't believe it's a true infection, and that's part of the problem. As an ID guy who's been around for a while, I can have a little bit more ability to say stuff like that. But a lot of folks just give up and say, okay, put them on some antibiotic that's there. And that's not the thing to do. And then skin contamination of blood cultures. A lot of blood cultures being drawn. You're seeing a lot of coag-negative staph. And now that you're able to identify all the different types of coag-negative staph, it's leading to more and more antibiotic use. In fact, I bet you I put one of my kids through school because whenever they change the name of a bug, we end up getting lots of ID consults for that reason. What is this? And you go, oh, it's really the same old bug, different name. And then another cause of antibiotic use is, post-surgical fevers. After orthopedic procedures, almost everyone has a little bit of a temp for the first, 48 hours. In fact, by day 5 is when you really start crossing the infection versus non-infectious type for major orthopedic procedures. The same thing goes for heart surgeries, CABGs, and neurosurgical procedures. And so a lot of antibiotic usage because a lot of anxiety because you don't know exactly what's going on at that time. And the downside of not treating could be significant. This was the MMWR in 2013 with the New Delhi metallo-beta-lactamases with ERCPs, and this was a outbreak that occurred throughout the country, and it had to do with the side viewing scope. Now, my experience with NDM started in 2008, 2009, when I was part of a program. I work in India quite a bit. I used to a lot more back then before all this COVID restrictions. And so I work with the what's called the Public Health Foundation of India, which is a Gates undertaking, and we were talking about multi-drug resistance to the Delhi city hospitals. Now, those hospitals are all 4,000, 5,000 beds. There are about 6 of those hospitals that serve basically the poor. And the first thing I said is, well, it's a New Delhi metallo-beta-lactamase, and the guy pulls me aside. They said, if you say New Delhi one more time about this beta-lactamase, we're going to ship you out of your own country here. Because because they were really into medical tourism and they thought it was going to kill their medical tourism industry. But sure enough, this NDM, which is a metallo-beta-lactamase, started out in Southeast Asia, whether it's India, whether it's Pakistan, Bangladesh, or somewhere else. It's somewhere out there, and then it spread throughout the United Kingdom, and then later recognized in the U.S. And now you can find it in your friendly LTAC and nursing home, not infrequently. So how did all this happen? Well, only in 1928, not that long ago, penicillin was discovered by Fleming. In 1940s, penicillin became a weapon of war. We had penicillin, and almost immediately we had resistance. And by 1960, we had more broader spectrum use of other beta-lactams, and then you soon had MRSA, which followed in the Boston City hospitals. And that was a big outbreak. By 1980, you had a lot of gram-negative rods, and then you had the return of MRSA, VRE, and now Loyola first described about this VRSA, which was this thickened, which is a MRSA, which was vancomycin resistant, the glycopeptides, which have been around forever and a day. And that had a unique mechanism of a thickened wall. And then by 2000s, we have, fungal pathogens, gram-negative bacteria, and the fungal pathogens, you ended up having, this Candida auris, which came out, again, of South Asia. And we'll talk about why that happens. And then by 2010, you have pan resistance, and you really had the end of antibiotic era because I've had patients where we had nothing to treat them with. You give them colistin resistant, and you're basically, it's a hope and a prayer, pull all the lines and see what happens. So this was published in 2018 as pets being an issue for acquisition of multi-drug resistant organisms. And this is published in PLOS. And basically, they had pretty good livestock data that showed that you had transmission of MDROs and resistance encoding mobile elements, transposons and others, from animals to the microbiota of humans. Now, and so this had a big implication for the livestock industry, as well as the industry, the pigs and others, because people can now catch this from animals, and then you can spread it amongst people from person to person. And this is not a new concept. This concept has been known for a while. And there's a lot of complex interaction of microbes. And we think that a lot of this stuff that we're doing is because of hospitals. The good news is most of it's not because of hospitals. The vast majority of microbes have acquired their resistance from eons ago. And this was shown definitively multiple times now with Cloveria and Shevanella isolates found in the environment, which already have a CTXM gene and beta-lactamase genes and multiple genes that basically encode for resistance. Fosberg and Science at that time used a new technique where they were able to take a soil and run resistance patterns on soil with whole gene sequencing, and they were able to find resistance to all 12 antibiotic classes. And by the way, this has been repeated, and this is repeated in the Arctic tundra, in the Sahara, in Amazon basin, in the plains of the United States, Australia, and they found the same exact gene sequences all over the place. So the soil resistome, okay, which is a concept of resistance present in the soil all around you, has been there forever and eons, way before humans even thought about antibiotics. So this is an important reservoir for exchange of resistance genes. And the classical example is an Acinetobacter infection. Acinetobacter infections, which we're all dealing with now, were not present in the hospitals a long time ago. These all really came to spread after Vietnam War, when you had the war in the tropics where Acinetobacter is present. And they were brought over to Rhinestein Air Force Base. And then from there, it spread over to the United States and all the VAs. And then we started seeing more of this because it requires a warm environment with moisture. And the best place for that is an ICU. And the same thing happens with, by the way, this was also seen when we had the tsunami, where a lot of them ended up having similar sort of issues with the injuries, and they ended up having Acinetobacter coming back to the same airbase, by the way. And Chromobacter and Pseudomonas isolates originating from farm soils have the same sort of these cassettes, which can jump from bacteria to bacteria. And one lineage of MRSA, Staph aureus, which is CC398, and most of the staph that's spread in the U.S. is not this in the hospitals. It's USA, I think, 300 strain. And these bacteria exist in pigs in great amounts, and they're shared between livestock and humans. So this is an illustration basically that talks about this. It's not quite as simplistic as this, where humans are using antibiotics for both humans and animals, and then the sewage gets dumped into the environment. You have to understand the environment already has this. It can just accelerate this process. So this was recently published, which I found fascinating. And basically, this article talks about emergence of MRSA, which predates the clinical use of antibiotics. This is done by Jesper Larsen et al. And what they did was something very interesting. They went out and checked hedgehogs. And hedgehogs are these cute little animals that are present in the UK. And then you go, well, what the hell is New Zealand doing out here? Well, the British love their little hedgehogs, so they took them to New Zealand also. And what they did was they looked for MEC-C, not a MEC-A like we have, MRSA clones in Europe and New Zealand. They found them in all these hedgehog samples throughout. And then they went back and they looked at what was the oldest, when was this introduced to New Zealand, because there was no hedgehogs in New Zealand. And lo and behold, they find that the MEC-C gene predated antibiotics by a good 100 years, okay? And there's several types of MEC-C genes out there that do this lineages, and it was also present in New Zealand the second the hedgehogs got there. So clearly, these animals have an ability to have MRSA and have these transmissible genes present. So in conclusion, they described an ecological and evolutionary mechanisms that led to emergence of MRSA in the pre-antibiotic era as co-evolutionary adaptations of Staph aureus. And it talks about why you really need a One Health concept of, recognizing the role of natural animals, natural selection in wild animals, and the connectivity of what happens in nature, the agriculture, and the human ecosystem if we want to really stop the spread of antibiotic-resistant pathogens. And the reason why this becomes important is in the 1950s that people found that when you gave antibiotics to chickens, they gained a lot of weight. And that's why, in the 1950s, you ate a chicken. The chicken literally lived for at least a year before you slaughtered it. The average time when you go to Costco and buy your two big pieces of, the two huge chickens with this abnormal breasts pieces, those things have only lived for about 6 weeks. So they've accelerated this by using antibiotics. And now they've stopped using it for a great deal in chickens because of the outcry, because of resistance. And this was first used in bovine mastitis. Penicillin was used. And then Moore et al. Reported in 1946 that the chicks gained weight when streptomycin was added. And by 1949, they were using chlorotetracyclines. And then later, you started using in swine, and quickly had E. coli that was resistant to tetracyclines in no time. Currently, what the farming industry uses, unlike humans, in humans and pets that we have at home, we only use antibiotics generally when there's some sort of illness. But for the animal husbandry industry, they use them for weight gain. They use it to prevent prophylactically, to prevent shipping fever, because the return on investment when you use antibiotics is about 3 times the cost of the antibiotics. And so when they sampled animals, they found VRE that was resistant prior to the release of antibiotics for human use because of the use of this drug called avoparcin in animal feed. There's a 3rd-generation cephalosporin called Cefdifur, which is a 3rd-generation cephalosporin, and they use it in baby chicks and they use it in piglets to prevent infection and to decrease their mortality. And they give it to not just one piglet that's sick, they give it to every piglet that's born and every chick that's born. So when you have this, what you end up doing is creating carbapenemases. And they actually found in Japan and in other countries, when the Cefdifur was used, they found a high incidence of carbapenemases and 3rd-generation cephalosporinases. And then they stopped using it, and of course, it dropped down again because the selective pressure went down. And farming has changed. When the farms were around in the 1970s, most farmers had 5 to 10 pigs on their farm. Not anymore. If you're driving down I-55 or drive through Iowa or drive towards Nebraska, as one of the speakers is out there, you see these massive sheds with these massive pig farms and all the effluent that comes out of the pigs. And these animals have lots and lots of multi-drug resistant organisms in their stool. And there was a big outbreak, I think, of a bug called Pfiesteria at one time in Virginia, when one of these big sluices would contain all the sewage fell in, and that had a bacteria that basically would eat holes in the fish. So they have a very unique sort of bacterial milieu that we're creating. So where do most of the antibiotic usage goes to? It actually goes to cattle, chickens, and pigs. And now, with the evolution of farming, seafood farming, especially salmon and catfish and other fish that you're picking up, there's actually a tremendous amount of antibiotic use in those animals, the fish. The problem with fish is they live in water, and the water has to go somewhere, and so you're getting it all over our soil. And so now the FDA started restricting livestock use, and then what happened is we've seen shifting of a lot of the antibiotic usage to other animals, and they use different reasons to use antibiotics. The actual antibiotic use has not dropped tremendously. So you're having this milieu of soil which has already pre-made antibiotic resistance, and then we're adding more antibiotics to our animals, which increases the amount of transposons and other genetically transmissible material. And so you're having a tremendous amount of pressure and food that gets contaminated, not just meat, but also the amount of vegetable matter that gets contaminated. And you go, well, how do the vegetables get contaminated? Well, what do they use to fertilize the plants? They use the pig feces and they use the cow feces, and that's how you end up having all of these E. coli outbreaks and other outbreaks by eating vegetarian, basically vegetables. So what are the big clinically important bacteria in hospitals? Basically, you have MRSA, VRE, C. diff, and CRE. Now, MRSA, I think, goes in cycles. You have 20-year cycles of MRSA going up, and the Staph aureus going up and down, up and down. And MRSA is just there because of this USA 300 strain, which with the MEK gene has gone through this country and occupies a niche because of antibiotic pressure in long-term care facilities and nursing homes. And basically, we need to use more and more antibiotics like vancomycin and other glycopeptides to treat it. And the common mechanisms of resistance are to this penicillin binding protein here. But you also have VAN A and VAN B resistance, and then with the remodeled peptidoglycan. And then the versa is when you have this very thickened wall and vancomycin gets trapped in the thickened wall and doesn't allow the glycopeptide to work. So this is, I'll go through this quickly because it's not that important, so because it's been described multiple times during talks. But basically, there's lots of MRSA coming out from the community, and it's found in skin. And as long as you drain the MRSA, you don't need to use a prolonged course of antibiotics. So VRE is kind of an interesting bug because everyone wants to treat VRE, but VRE is like, to me, the cockroach of bacteria. It hangs out. So if you have a clean environment, you don't have a tremendous amount of bacteria. But if you have a dirty environment, you end up having lots of other bacteria that go along with it, VRE, CRE, and other Enterobacteriaceae. And so this used to be a big deal because we used to think that vancomycin drove this. I'm not sure that vancomycin use drives this so much, but selective pressure of all different antibiotics drives this. And it's spread by direct contact by hands and by flat surfaces. So the environment becomes a big deal of how to manage most of the spread in the hospitals. This is by Mary Hayden and Amy Duckrow, who were fellows way after me in a long time, far, far away at Rush. And it basically showed if you drew a circle from the anus, you can increase the concentration of basically VRE in these areas. And the contaminated surfaces were the flat surfaces on the touch points around the guardrails, the ubiquitous table, and as well as the IV pole and flat surfaces. The problem with the IV poles and those instruments are there's always a fight between who gets to clean it, and nobody puts their hands up first. Environmental services can't clean it because they're not nurses and they're not meant for that. So nurses don't want to clean it because they feel they're not environmental services. So this is all like this little war that goes on, and in the end of the day, they don't get cleaned. The monitors don't get cleaned. And then they have an increased risk of transmission, not just of VRE, but when you have VRE, remember, you're probably going to get other bacteria on there like CRE and Candida auris, because you really need good cleaning of surfaces. And so people at increased risk for this are people with weakened immune systems, lines, indwelling percutaneous devices, and we're seeing more and more of that in the hospital. And these environmental pathogens survive a very, very long time if unclean. C. diff is a spore, so it lasts forever. Staph aureus actually desiccates and lives for a long time till it finds the right environment to grow again. Acinetobacter in the right moist environment can live for a long, long time. And my favorite, of course, norovirus, which is hard to clean. It can hang out for a while. So COVID and SARS, they don't last that long. HIV doesn't last that long. And so the key reason why I put that slide up there is environmental cleaning, not just antibiotic restrictions, is key to decreasing the antibiotic usage in an institution, because that will limit your spread of MDROs. And so what happens when you start using antibiotics? When you use antibiotics, basically you're not killing one bug, you're killing everything around it. It's basically taking a nuclear bomb and wiping out gut flora, as well as other flora of your sinus cavities and everything else. So the unintended consequences, you're killing off most of the microbiota, and it takes multiple weeks for these to come back. And then resistant strains persist with the use of antimicrobials. And those resistant strains, when you use antibiotics over and over again, grow, and then you end up spreading it in the environment and then spread from hands going from place to place. And this is what happens with C. difficile colitis. It's very interesting. C. difficile become a very political creature in the hospitals. Most of the C. diff that occurs in the hospitals is not C. diff that's spread within the hospitals, but there are small outbreaks that do occur. Most of them is because people come in with it, even from the community. And now it's a game of chicken where Center for Medicare Services doesn't want to pay for it. So within 3 days, if you have C. diff, they'll pay for it. If it's not, then the hospital's up. So after 3 days, it's an act of God to go out and get the C. diff test in most institutions, because that's been the administrative measures that have been put in place, even though there's very little scientific basis for doing these things. But the golden rules, Dr. Chundi's golden rule still applies, which is those with the gold make the rules, and that's the rule that they made. So when you give antibiotics, the microbiome is very highly vulnerable to invasion by pathogens. And that's what happens when you get C. diff. So this causes a severe colitis, and the major mode of transmission is by environment in hands. And basically, it's a leading cause of hospital-acquired diarrhea. And most of the work, a lot of the work that's been done has been done at Loyola by Dale Girding et al. From a long time ago. And this was from 1995 with Dale Girding, who went through this. And you can see the numbers of C. diff is increasing. It's kind of leveled off. And these are the major toxins that are present. And now you have a hypervirulent strain. And I won't talk about this because there are other sessions on C. difficile. But basically, if you're older, you have a higher risk of C. diff. If you've been on antibiotics, you have a higher risk of C. diff. If you've been on chemotherapy, you have a higher risk of C. diff. And if additional risk factors include, guess what, using a lot of PPIs and immunosuppressions. And lots of almost every patient that walks into the hospital is on a proton pump inhibitor. The classical risk factors we already talked about, antibiotic therapy, advanced age, long-term care, staying in a healthcare facility long term, and severity of illness. Again, a graph that just shows you the older you are, the worse it gets. And then people with long-term care, if they're in the LTAC for a long-term, they may carry C. diff spores for a significant amount of time. And this NAP1 strain, which was described at Loyola, is present all over, and it causes a very severe course of C. diff. And the key to all of this is restricting the duration of antibiotics. So the mechanisms of gram-negative rods are a little bit different. We're going to run out of time. Let me just get these two pages there. Otherwise, it keeps on ringing. Sorry about this. All right. So gram-negative rods are a whole different ball of wax because your gut basically has E. coli as a major gram-negative rod, but other gram-negative rods are present. Lots of anaerobes are present. In fact, the anaerobes far exceed the aerobes. And if you take all the bacteria in your gut, there are more bacteria in your gut than all of your own cells, and most of them are gram-negative rods. So in the gram-negative rods are multiple mechanisms of getting rid of antibiotics. Porins are these little tubes that will push out the antibiotics, and in nature that seems to be a major mechanism. And then you have all sorts of modifying enzymes that modify the enzyme that it gets processed by. Then there's target mutations like in quinolones with DNA gyrases. And then you have ribosomal mutations with tetracyclines with the TET-M or TET-O, which alter the protein there, and aminoglycosides with methylation. And then we use trimethoprim sulfa, basically dihydrofolate reductase and dihydrotarate synthase changes. And then in polymyxin class of antibiotics, they change the actual liposaccharide structure. And then in carbapenems, they actually have carbapenimases, which we're dealing with all the time now in the hospital. So lots and lots of these, and these are encoded in these little transposons that can jump from bacteria to bacteria to bacteria, and they're very, they don't just go from their own type of bacteria; they go to all different bacteria. So E. coli, Pseudomonas, they share all this. They're very promiscuous that way. So these are large carbapenimases. They're a large group of diverse enzymes which hydrolyze carbapenems, and carbapenems are exclusively used in humans. They're not used in cattle or other areas. And basically there's a classification, an Ambler classification. And now you have this massive problem with KPCs, carbapenem, or now we call them CREs. And it's a massive problem in long-term care facilities as well as LTACs in our hospitals. Go through this, we don't need this. And then you had the NDM, which encodes for basically all classes of antibiotics except colistin. And interestingly, so colistin use has gone up throughout our institutions. And this was first described in Chennai, near where I come from, and then it was imported to the UK patient from the Indian subcontinent, and now it's all over the world. So this has not been contained at all, even though there were a lot of efforts to try to contain this. And this is the distribution of the first pandemic of all this. And these plasmids are the ones that are conferring this resistance to all classes of antibiotics. And this BLA NDM basically is now spread everywhere. So what is the infection control problem? This is in our local area. So you have healthcare workers' hands, which spread back and forth from the environmental surfaces. If you don't wash your hands, if you wash your hands, you don't spread them to infected patients or susceptible patients. But if you don't, but if you don't wash your hands, you're spreading them all over the place. And this has become a major source of concern, is hand hygiene. It's very difficult to get people to wash their hands. Every infection control place that I work at says they wash their hands 100% of the time or close to 80% of the time, neither of which I believe. When there was an observational study with cameras, it showed that at the night shift, it was in the single digits at times of who washes their hands. I think it's a little bit better than that, but I'm a skeptic. So the environment becomes a big deal of trying to keep the areas clean. There are new innovative ways of trying to prevent spread on the environment with different types of paints, different types of electrical charges. So there's lots and lots of things you can do. But the key message is, even though you may have resistant organisms, if you disinfect the environment, you're going to be far better off. If you're going to wash your hands, you're even better off than that. And then lesser use of antibiotics, you'll have less resistance inside the hospitals. So the strategies to combat resistance we've talked about all day long, which is diagnosis, the correct use of the drug with the correct dose, the correct duration, de-escalate as soon as possible, and document what you're doing. The problem with stewardship is you need better diagnostic to differentiate colonization from pathogenic bacteria and avoid prolonged courses of antibiotics. You need to optimize duration. Duration now is dropping more and more and more. You don't need to give 14 days, but I've always said that this is, you have 5 days of therapy because you have 5 fingers, or you have 10 days of therapy, or you go by the moons. There's 7 days, 14 days, 21 days, 28 days. None of it makes sense. There's very few things we know exactly the duration of antibiotic usage. Some of them are like endocarditis and meningitis we're pretty good with. The rest of the stuff is, up in the air. Lesser, I think, is for the most part better, except for a few exceptions like Pseudomonas and Acinetobacter pneumonias. And then better tests to help stop antimicrobials. The use of procalcitonin, not for diagnosis, but to de-escalate and stop for pneumonias, is well established and should be used in almost all antimicrobial stewardship programs. And you need to de-escalate antibiotics when no resistance is found. If you can just do these two things, you would have achieved a lot more. De-escalation of antimicrobials. The problem is, so a person gets surgery and the patient is getting better, and then you have them on meropenem, and then you get the cultures back, and it's basically very sensitive E. coli, and they continue to be on meropenem. It does not make sense. So you should try to get them to the narrowest spectrum antibiotic as possible. And this is the next step in all of this, where there's multi-billion-dollar effort to basically characterize what is the human genome and what bacteria exist in the human genome, not just in your gut, but the sinuses, the ear, the vaginal human genome, microbiome, not genome, microbiome. And so you could basically harvest this microbiome. I don't think it's as simple as that, because I think it changes in you as you go through your life, and then put it back into you after you've used antibiotics, so you recolonize you bring back what's called homeostasis. And so that's going to require continuous monitoring of the human biome during health. And then in sickness, you can take that same genetic material of these bacteria and then inoculate it back into the person so they get back to where they are. And interestingly, when a baby is born, they're born sterile with their gut. But within a few days, they get their mother's bacteria. And within six months, they get both their mother's and father's bacteria. And their microbiome is kind of set by the time they're a year. And then it changes over time based on your exposure. And this microbiome alters with various things. And now you know that if you can basically never take an antibiotic, you can basically eat food somewhere, and that food is likely going to have a resistant bacteria, and you can have resistant bacteria in your gut. That's why study after study after study shows if you come from Southeast Asia or you come from South America, Central America, your incidence of ESBLs is significantly higher than other places in the world. So what you're trying to do here is to establish a baseline, and you monitor the microbiome during illness, and then you bring it back to baseline after treatment with antibiotics. And the fecal transplantation seems to be one step in this. It's not really refined yet, because you still have to explain what is in that. You're just basically taking commercial bacteria and then trying to put it back, whereas each of us has our own microbiome. So we need to identify more of these very specific microbiomes and disease states. What are the bacteria that cause disease states, and how do you bring it back? And so I'd like to thank you there, because here's a kid kissing a pig, and that's how transmission takes place. And I think we have 10 minutes for questions. Dr. Mahajan.
Thank you, Dr. Chundi, so much for
Can't hear
wonderful presentation. I just was just emailing the moderators about the technical issue I had early on, so I apologize if I wasn't able to introduce you properly. So everybody, that was Dr. Chundi in flesh, one of my mentors and great attending for a lot of our residents that have, and medical students that have rotated through the hospitals where he has provided care and teaching. So thank you very much for that. I just again, a lot of the career decisions were made because of your excellent teaching and just overall bubbly personality that has been so good. So I think I have, I guess, the most fascinating question here, and Crystal Bear, she would like to know, could you please repeat what is Dr. Chundi's golden rule? And my add-on to that question is, have you copyrighted that?
Those with the goal make the rules, and a lot of it doesn't make sense, because it's very difficult to be in an administrator's head when they make those rules. But we got to follow them. And antibiotics.
So say that one more time. I think I personally didn't follow that when you said. So the golden rule is.
Those with the goal make the rules. I mean, it's not the golden rule in the Bible, which is do unto others as you would have done unto you. And so this is completely different.
So as we have other questions pop up, if you were to give us commoners practicing in acute care setting and trying to be a little more antibiotic and smart with, I think, we've repeated this topic multiple times, a lot more in LTC, but also in smaller community hospital setting. A lot of times the concern from non-infectious disease physicians and advanced practitioners is, what if I not give big guns at the get-go and the person becomes septic, especially older adults, the ones who can't speak up with their symptoms and might not manifest some of these golden, or these classic signs of infection. So if you were to give us like one or two pearls of wisdom on how to go about that person arriving to the floor or ED with their early signs of infection, but not something cooking right away in a culture or in a diagnostic confirmation.
So, the answer to that question is it's next to impossible not to start antibiotics when someone comes in from a community or from an area where they're sick. Okay. The problem is on 48 hours, not on get-go. So you've got cultures for 48 hours. The cultures are negative, or you have a bacteria, let's say pneumococcus, and now you can rapidly de-escalate to where you need to go. So let's say at 48 hours, the cultures are negative, but the person is hemodynamically unstable. You should go search for another reason for that hemodynamic instability. And clearly by 72 hours, if all the cultures are negative, you have a pretty good basis to either stop or de-escalate based on the clinical findings. The problem is people continue them on vancomycin, a carbapenem drug, as well as an antifungal, and it keeps on going. And that needs to end. The use of, if you say, let's say a person comes in, they think they have pneumonia, and you get a procalcitonin, the initial procalcitonin is 2 or 1 or 0.8. Okay, and then it drops down and it downtrends. You have a pretty good basis for stopping the antibiotics on day 5 even. There's lots of data from Nina Singh et al. That shows shorter courses of antibiotics in most pneumonias are equivalent to longer courses of antibiotics.
Yeah, thank you. I think that's takes us home with this, and okay, we do have a few things pop up here, and I'll just read those. So, how should infection preventionists approach providers um, um, when drill downs identify antibiotics were potentially inappropriately used?
I think the way you say, hey, you present the data. I mean, people who use lots of antibiotics usually stand out in the crowd. And what you need is individual practitioner data on use of antibiotics per diagnosis. And if you just, doctors are very responsive to this. If you just show how one doctor compares to another, and they respond pretty quickly at bringing themselves down to the average or below average, because everyone wants to be the best at what they do. And I think you feed back that data. It's a very effective tool for good stewardship. But stewardship by itself is not going to cut this. I think the environmental cleaning is key to prevention of, having lots of transmission, because, what happens in India is now they have so much ESBLs everywhere. The starting antibiotic is a carbapenem in India for everybody. Okay. And it's created a huge issue there. And you don't want to end up like that here, fairly quickly. I mean, we do that in Chicago and New York, and there are a couple of cities that have high incidences of resistance. There are other places that don't. And it has to do with the resistance pattern in those cities. Anything else, George? Can't hear you.
So yeah, so we do have a few questions that popped up, and so we just quickly. So one question is on various groups like USA PIRG have advocated for petitioning for small changes to reduce antimicrobial resistance, such as hospital cafeteria changing to antibiotic-free meat. Given the ubiquitous nature of antimicrobial resistance in our society, even plant material, do you think these changes are worthwhile? Big and small initiatives. Yep.
They're huge, but it has to be on a national level. It cannot be, okay, my household is going to eat antibiotic-free meat, because what happens when you go to a local restaurant? It has to be a national policy. It has to be a policy that's just not meat, but also vegetables. And it has to do with water management, because a lot of this is where the factories are that manufacture antibiotics, and they're effluent, which are full of antimicrobials, and then they're not processed and they put them into the water supply. And there's lots of data out there that show wherever you have these large farms, chickens, pigs, cows, the soil has a much higher amount of resistant bacteria. And that soil is a living thing. And so people then acquire resistance in those areas. And that's a massive problem. The city I come from has a large manufacturing base of pharmacies. In fact, a lot of the generics you take come from the city I come from, Hyderabad. And they were dumping it into the local water supply. And the resistance rates in Hyderabad are off the wall because everybody is drinking this stuff. It's in their water supply. It's just the best way of getting pan-resistant bugs.
So one more we take before we end this. It's from Jacqueline Valentine. In your presentation, you mentioned 3-day calendar day window for C. diff testing. Do you feel standing orders aid in early testing to capture community-acquired infections, or do you feel that poses the risk of testing the colonized patient, given the patient do come into hospital with other etiologies that result in diarrhea presentations?
Well, most diarrhea is C. diff in this country, unless they're travelers or come from outside. I mean, the 3-day rule that testing is basically money-based, right? Several large institutions have rectal screens on almost everybody who comes in. So the 3-day rule is based on what CMS pays for or won't pay you for C. difficile, and then ding you. And so it says basically, you got to live with that rule until CMS changes that rule and says, you're free to order C. diff and we won't hold it against you, because the data shows that when they have actually taken this C. diff and looked at where it is. Most of this C. diff is not acquired within the hospital. It's their unique C. difficile in their colon. It's not like this patient spread it to patient A to patient B to patient C. I mean, yes, there are small cluster outbreaks that occur in the hospital on and off. The vast majority of the C. difficile is from the community in the hospital.
So with that, I think those were mainly the questions asked, and I thank you everyone for joining us, and you found this as helpful as I did. And thank you again, Dr. Chundi, for doing this. I know you're extremely busy. It was very helpful. So everybody else, we have a couple more sessions coming up. We'll see you there. Everyone have a good rest of your meeting. Thank you.
Thank you. Thank you for having me. Thanks, Dheeraj.